actually thank you for letting me come and chat with you guys today. I know you guys are out there doing this work, and it is just a joy to get to talk with the folks that are really making this happen. My day job is implementation, and implementation of hard stuff and real practices, and it's just hard, but we do it, we move forward, and because we know that it's ultimately good for the health system and the patients and our communities to do these things. But I really do empathize with you all, and I can't wait to hear more from you guys about how this really want, first of all, to let you guys know that we made these slides for the Stroke Advisory Council. So some of this you really know, and I'll go through that stuff quickly. But we did this for a group who maybe has heard of Compass before, but very importantly, I wanted them to know where along the way we actually collected this data and to make sure that folks in the room understood a little bit about Compass. But I really wanted to start, even with that group, reminding everybody there's a national effort, this Million Hearts campaign, which funded so many studies, large studies like this, and other kinds of studies on preventing cardiovascular disease, the work that we're doing in stroke. But there was this whole effort to say we need to take taxpayer money and really put it into cardiovascular disease treatment and prevention, because this is one of the largest issues going on in our country. Yes, it's a huge expense, but of course it's causing a lot of morbidity and mortality. So there's this massive effort going on, and Compass is really just part of that. But with that comes a very strong message that this kind of stuff can only be done when public health and clinical medicine come together. So if we're going to really address what's called the ABCs, and there's aspirin, cholesterol, blood pressure, and smoking, and all these other things that are wrapped up in cardiovascular disease, has to be a combined effort with public health and clinical medicine. And most of you on the phone have probably been trying to bridge those two worlds for a lot of your career. Certainly I have, and Sylvia has. But I wanted to remind everybody about where this even started. And even Compass, as big as it is actually a small part of a much bigger campaign to see if we can't move our country forward. And can we combine, can we really do a good job by getting public health and clinical medicine together? So that's it. But there's a perspective piece in the New England Journal on this. This one was more specific to, heart attacks and stuff, but these are, these are birds of a feather. So I wanted to remind everybody of that. And what I did for the Stroke Advisory Council, like I said, is first we just kind of went through the Compass study very briefly. But I wanted them to understand the patient-level participant flow, like what does the patient see? And then where was this data that we're all going to share together? Where was this collected along that flow? And so that's how we did this. Of course, we reviewed the objectives. You guys have seen these, but let's just reflect. Why are we doing this? We're going to address the needs of stroke survivors and their caregivers, connect hospitals, community providers, and agencies, and very uniquely in our project, develop this e-care plan. This is new. This is novel. Having a care plan that's electronic, that someday will be able to be used by multiple partners and clinical folks and others caring for patients, that can be dynamic, and it can change as the patient's condition changes. This is really new, and this is really cool that Compass is trying to do this. And it's an expectation for all of us in the future that a care plan is dynamic, of course, because everything's dynamic and the patient's condition is dynamic. But that's one thing that's really different about Compass. So then the other question is, why post-acute? Why are we looking at what happens to patients after they've had their stroke? Shouldn't we be looking at EMS? Shouldn't we be looking at call 911? Shouldn't we be looking at what's happening in the hospital setting? Well, of course, we should and we have, but this study is taking that big leap to say now a patient's actually transitioning back into their communities, back into their primary care settings, and what do they need? So again, this is unique that we're having this major focus on on the post-acute phase. And why is that important? Well, half the stroke patients in North Carolina are discharged directly home. after they've had a stroke. And as you can see, many of those, 44%, cannot ambulate or walk independently. Less than half even have their stroke risk factors assessed. So what do I mean by that? Has their blood pressure been checked? Has their A1C or their diabetes measures been checked? Have they, had some kind of routine analyses and assessments to make sure that things are under better control so that we can prevent a repeat stroke? And this is just a reality. And look at the readmission rates. Within 90 days, a quarter of these folks are already readmitted to the hospital. And I am sure everybody on this phone knows how critical that is, how hard that is on families when that occurs, and patients, the additional risks that patients, endure by going back to the hospital, and of course the expenses to our healthcare system. So that's why this whole grant was put, to focus on post-acute. We've got these issues in the post-acute setting, so let's go for it. So here's what we showed the Stroke Advisory Council about the participant flow. We just made sure they understood that patients are recruited at their hospitals, so if someone has a stroke, they're identified within that setting as best as possible. They get these wonderful materials in their blood pressure log. They meet wonderful people like PACs who start these initial assessments with the iPad. The 2-day call happens. We use a lot of pictures, as you can tell, because we want we want people to see the face of the patients and the providers, the clinicians like you all that are part of this process. And then, of course, what are some of the things that you all do for these patients when you're talking about transportation and reminding the patients and the families of the signs and symptoms of stroke. So we make sure we share that. And then we share a bit about the 7 to 14-day visit. And again, I think these pictures are just worth a million words. You're really going over what kind of stroke did I have and where was it? Where in my brain, how does this make sense to a patient about what happened? What are the deficits that you all are picking up that a regular quick exam may not be picking up? What are the specific stroke things that we can pick up in this critical 7 to 14-day visit? So we make sure we chat and share that with folks when we talk about COMPASS. More again about the fact that there might still be outstanding cardiac monitoring. And maybe this patient has atrial fibrillation and it hasn't been figured out yet. Maybe that's why they had their stroke. So what is the, additional tests and things that still need to be followed up on after the patient goes home? And then, of course, generating this e-care plan, making sure folks really understand all that. So I know you guys know all this, but I want you to know when we're out, messaging, we're making sure that people see the faces and the tools and the everyday stuff that really goes into the hard work that you guys are doing. And as a researcher, I'm always very careful to make sure people know when the data that I'm going to show you was actually collected and how that data was collected, because that really should make us think about the interpretation of the results. So the results that you're going to see are the results that were captured at this 7 to 14-day time interval. So you all know this, but there's a post-acute functional assessment. You may call it something differently, but that's what we call it. And the advanced practice provider assessment, those questions, then all the answers to those questions feed into the e-care plan that you guys all know about. But again, this is new, so we really make sure people understand that. So the questions asked at this part of the trial feed into the e-care plan, all right, which is different than going to a study and having a research assistant do a baseline assessment and then following up in 6 months and then following up in 12 months. We are also doing that in this study. But for the data you're seeing today, it was mainly from this part of the study where you guys are asking these questions and then we're developing the e-care plan. So let's get into the data. Someday this number will be 3,000. That's the number of folks that we expect once the trial is really up and running and finished. We'll have data on at this point. So what we're sharing with you today is the first 342 stroke survivors and the data that you all helped collect. So among 342 stroke survivors who were discharged home and seen by the PAC and APP team, this question or some of these other questions were asked. Do you know any risk factors that may lead to a stroke? And then my understanding was that then the patients were asked, what are the risk factors, or what are the, things that increase your chances of having a stroke? And then the patients were supposed to spontaneously come up with these options. Like, what did they name? So what's that general knowledge out there among patients and caregivers about the risk factors for stroke? And you guys have seen this. And then, a few other questions. But anyway, that's where this data comes from. So first, I'm going to show you the data from all 342. And this is simply how we're going to, show this now. So among those folks who were asked that question to list their risk factors, 217 noted that high blood pressure was a risk factor for stroke, 64%. And I'm going to give you just kind of this is my N of 1, kind of how do I feel about that number, but of course I would love to hear what you guys think about that number. That's not terrible. Could it have been 80? Would I felt better if it was 80? Yeah, maybe. But, that's not terrible. Kind of like that half, glass half full or empty. If you flip this on its head and say that, well, I'm doing quick math here, 46% or 36% didn't know it, 36% didn't know it, yeah, that feels not so great. I mean, these patients just had a stroke, right? They're 14 days from having a stroke. So let's look at some more. 95 chose or noted smoking as a risk factor, so only 28%. This is more concerning to me. I would kind of hope that we have a general knowledge base that smoking puts us at risk for these types of things, but again, that's just my reflection. 21% noted diabetes as a risk factor. We're asking all comers here, not just those with diabetes, so that is what it is. 43% noted high cholesterol as a risk factor. That felt a little low to me. Only 6% noted atrial fibrillation as a risk factor. That doesn't shock me too much because not that, you have to know what atrial fibrillation is to have been able to then said that, remark that way. 38 or 11% noted that heart disease was a risk factor for stroke. And I do want to share with you, we've got some primary care providers that we pull in and show this data, and they're on the Compass Grant kind of with us. This is the one that was most disturbing to them, was this notion that we're not connecting heart disease and stroke in kind of the same bucket. And we should. And so, the feedback I got from the primary care folks is we need to just keep saying heart attack and stroke. Heart attack and stroke. Don't say these fancy words, cardiovascular disease, ischemic heart disease, heart attack and stroke. If you think of the vascular system like a tree, and think of the big wide trunk at the bottom, and think of that like it's a blood vessel. It's wide open, it's huge, it's got a big diameter, the things are flowing. But as you go further and further out on the limbs and out on the branches and then to the tiny parts of the branches and then to the leaves, any kind of disease that clogs that system, okay, the further you get out, the thinner the vessel or the thinner the tree limb in this, whatever description is, the more at risk those tissues are of actually being able to get blood, which is and oxygen and other nutrients. So the end organs that we talk about, our brain and kidney and our eyes and our heart, it's really all one big system. We could certainly discuss the differences in how you cut these things up, but we need patience to understand the connection of these. We've got to lump them more in making sure that people understand that they've had heart disease. That's really very much a risk factor for stroke because of this thing that I just talked about, the analogy with the tree. So this was the one that was most disturbing to our kind of primary care colleagues. And then, again, whether or not physical activity and inactivity was noted as a risk factor, I'm not so sure that many people would have come up with that, but I would love to hear your guys' feeling about that. at some point, because you're asking these questions. And so it'd be nice to know actually how they were asked. But I wanted to give that little bit of caveat about some of that data. So as a health services researcher, I'm a little bit more interested in the next way we look at this data. So this is the same questions, by the way, but among those patients who had a certain condition or lab value or blood pressure when they were at your 7 to 14-day visit. So they were there, they had it. Which ones did they actually acknowledge as a risk factor for stroke? So this is a little different. The first data was everybody that came, name your risk factors. Okay, this is, and I'll give you an example so you see where I'm going. Among the patients who actually had a systolic blood pressure of 140 and greater, which is consistent with uncontrolled hypertension, how many of those folks recognize hypertension as a risk factor? So come with me to understand we're kind of looking at a different denominator here. So among 116 subjects that had this blood pressure of systolic of 140 or greater, 68% said, yeah, hypertension's a problem. Yeah, I'm real glad that they noted that, but they just had a stroke, and hypertension is such a risk factor for having another stroke. They're at a time interval where their risk of repeat stroke is so high that first 6 months to a year after that index stroke, it would be lovely to see this number get better because these are the people that they're coming in high. Now, do they know they have hypertension? I don't know. That's not the way that's not the way this data was collected. Do they understand hypertension? Have we, as a healthcare community, made it make sense that they understand they have high blood pressure and what that really means? Who knows? This is the data, and this is what we have, but this one I really think is important. And now among the smokers, so if they said at your visit that they smoked, 69% of them recognize the smoking as a risk factor. You know, if I had a magic wand, this would not be 90 to 100%, but the data is what it is. Now, among those with a hemoglobin A1C, which many of you know is how we diagnose diabetes these days, you all went back into the EHRs, is the best that I understand, you know, kind of around the hospitalization, and you pulled out that EHR data, and if they had an A1C done, greater than 8's really high, pretty high, you know, uncontrolled diabetes. And among those, 64%, 18 out of the 28 or 64% recognized diabetes as a risk factor. Again, we don't know if these folks knew they were diabetic. We just know they had an A1C within the hospital setting in that kind of time interval of an A1C, which was pretty high. And this is the same kind of data. So here's among those with a history of atrial fibrillation, 11 or 29% of these recognize that as a risk factor. So you're probably going to wonder, well, I didn't ask about AFib at that visit. I want to tell you that for this data collection, I did have the data analysts go back and pull some diagnoses out of another place where we're collecting data in this study. Okay, so for this one, I really wanted to know, okay, did the folks actually have AFib or flutter? And then did they acknowledge or recognize or state to you all that atrial fibrillation was a risk factor for stroke? This needs to be a lot higher. And I am not asking you guys to do this. We are sharing this data so that we have a sense and we can learn about how things are in our state so that we can go back and think about this partnership between public health and clinical medicine about our responsibility to message this differently, better, smarter, some way so that we can protect these patients better. This one was very important to me. And again, this thing with heart disease. So I went back, and you can see what we called heart disease in this enrollment visit way back when they were enrolled initially. So if they had coronary artery disease, or if they had heart failure, if they've had actually, you know, an MI or a heart attack, and then if they've had valvular disease, that turned out there's only 3 of those in this set. Among those, 89 what percentage of them had recognized heart disease as a risk factor for stroke, and it was pretty low, and that shouldn't be that shocking based upon, kind of what we already talked about. LDLs, again, y'all helped us go back into the medical record, pull out the LDL, and among those with an LDL greater than 100, 56% recognized high cholesterol as a risk factor for stroke. Obviously, it would be nice if that was higher. And then we asked this, issue of low physical activity versus moderate versus high, and folks are just not connecting the idea that their low level of physical activity might be a risk factor for stroke. And I'm not sure that many people make that connection, but there's where we can also improve, right, and see what we can do as an overall health community, healthcare workforce to enhance some of this knowledge. Now I want to show you in two different ways, but bear with me, what our blood pressure data was. So this is the blood pressure that you all got at the 7 to 14 day visit. So here's, this is fresh. This is the blood pressure when they're kind of right there with you. I have the actual numbers up in the little box to the upper right. And let's just focus on a few things here. We did have some missing data, so that means 7.6% of the time there either was not a blood pressure or somehow it just didn't get into our data collection system. So that's what that 7.6% is, and I have that kind of way over to the right, that empty box. But, there's a sizable percentage of folks that are coming in with these high numbers, like I said before. So the stage 1 hypertension, 140 to 159 systolic, 25% or 87. An actual raw number of 87 people. And then 29 people, or 8.5%, were stage 2 hypertension, 160 or greater, which is getting up there. And I'll show it to you a little bit differently, because again, I like to be really careful about my numbers and my denominators when I'm sharing data with people. As I shared, there were a number of missing. So what you're going to be seeing going forward is just among the 316 people who we had a blood pressure for. That's what you're going to see in this different kind of graphical form frequency distribution going forward. So you've got your systolic blood pressure. I don't have diastolic here. We're just focused on systolic for this talk. Going up there on the y-axis or on the side, and then the x-axis is participants, and this is just a range of the different systolic blood pressures that we saw. So certainly some people were coming in 90, these people are 100, 110, nice and normal. Our overall mean of this whole group, if I took all their systolic blood pressures and averaged them, was 135, and we used something called standard deviation there statistically to show kind of a spread of the numbers around that mean. And then here's, if I look at that 316, where we actually had a blood pressure, 116 of these folks, or 34%, were 140 and above at that visit. And the same data here with even higher, the stage 2 hypertensive, those 160 and greater were, if this was a brand new patient, you'd really be thinking of starting them on 2 meds, and really getting going and not waiting too long. But these folks, again, they just had a stroke. My initial impression of this was, well, it's in the office, they're nervous, maybe this isn't so bad. But my primary care colleagues, they did not like this at all. They did not like, this is nearly 10% of these folks, and they want to see the data when Sylvia and Rika and the whole team keeps accumulating more and more data. Boy, they want to see this one again. There's a lot going on in the state where we're organizing ourselves as ACOs and healthcare systems and whatnot. And fortunately, there's some really dedicated people who want to focus on population health better and come together and try to fix these things. So this data is going to be really helpful when we share this, which we already have with some of the ACO folks, to get a sense of what's really going on in our communities and in this very high-risk population for readmission and having another stroke. So I wanted to show it that way. Now my other bit of data, and I don't have a whole lot more, so hang with me. Over the years, I have certainly heard that one of the big issues is there's not enough primary care doctors to take care of these patients anyway. So what are we going to do about this phenomenal work that's being done in the hospital and then in the transitions visit? And then what? Who, where's the handoff? The primary care folks and others in the community are going to be caring for these patients for the rest of their lives. So is there someone, out there? And again, remember this data is among those who actually came to an APP visit, all right, do they have a doctor? And we word this in a way the best we can to try to get them to understand what that kind of everyday doctor is, who, flu shot, whatever, physical exam. And if you've had this doctor, have you seen him or her in the past 3 months? And have you seen them since your stroke? All right, they're at the APP visit at 14 days. Have they also seen their primary care doctor during that same time interval? That's busy. And here's that data. So one at a time, do you have one doctor that knows you and all your medical conditions? 93% of these folks said yes. This was really good news to everybody we've shown, by the way. And I do understand it's just those who came to the APP visit, and this is just the first 342 people. But this was really good news, and I feel like this says these people do, at least this group, they've got someone who, if we connect really well to, and really talk about the chronicity of this and the need to control their blood pressure and their cholesterol and their AFib and treat them well and get them back out there and living lives to their fullest, that there are people that are there to be on that end of all this. And have they seen them in the past 3 months? 85% said yes. Now, you'll see my denominator switching. What that means is the first question is, do you have a doctor? And then among those who say, yes, I have a doctor, did you see them in the last 3 months? So if you take a look at these slides later and really want to, think about the numbers, I wanted to explain that. And the same thing happens with this one. If you actually have seen that doctor in the past 3 months, did you also see them since their stroke? The primary care docs thought this one was a little too low, which, I don't know. I'd love to know what you guys think. They're already got the APP visit. It's busy. There's a lot going on within the first 2 weeks after your stroke. It's hard to get in. I thought, as has everybody who's seen this data, thought that this was really good news, that at least where we're starting from, there's care out there. Okay, I'm pretty much done. I just want to remind everybody that the questionnaires and everything in the world is on the Compass website. I send so many people here. And then Sylvia, I've got control of the slide, but Sylvia was going to mention a little bit about what we think we should do next, at least at the Stroke Advisory Council level, with this kind of data informing the action steps we want to take next. So Sylvia, are you good with jumping in?
Yes, thank you. Thank you so much for that outstanding presentation and putting it into language and into a manner where we can clearly understand it, and we'll have some discussion about it after we finish the presentation. So I just wanted to let you all know that we have been working on some of these issues at the state level. I know that some of you from time to time come to the North Carolina Stroke Advisory Council meetings, and we welcome you to continue to come to those. And we have now, under the Stroke Advisory Council, we have what is called a post-stroke health work group. And I wanted to just make sure that you're aware of that, number one. And we've been doing a lot of work for years in improving acute care for stroke patients, and we're doing a great job in that regard. And then after that, we started working very intentionally with EMS and bridging the gaps between pre-hospital and hospital care, and now that's all going really smoothly. We know how to get patients in quickly. We know how to take care of them. And then, as you all know, moving across the continuum, we're not doing as good a job as we could be doing and should be doing as we transition patients out of the hospital and back home and into their communities. So Dr. Pam Duncan, you all know Pam as our lead principal investigator with the COMPASS study, and I co-chair the post-stroke health work group under the Stroke Advisory Council. And we have Dr. Cheryl Bushnell, one of our other principal investigators, serves on this. You all, many of you know Betsy Vetter with American Heart, American Stroke, Dr. Wayne Rosamond, our other principal investigator, and several post-acute coordinators, whether they be in the control side of the intervention or in the intervention side, the control side of the study or in the intervention side. So just wanted to make you aware of that and let you know that you can see the slide here on the webinar, hopefully, that we have come up with 3 basic recommendations because we had to come up with some things that were actionable to present to the Stroke Advisory Council and hopefully this summer onto the Justice Warren Heart Disease and Stroke Prevention Task Force, which is our advocacy group to help us get funding to continue to move our important stroke work in North Carolina forward. So you can see here that one of the first things that we talked about doing is working with Medicaid to write a letter to providers describing stroke patients' available benefits. We know that a lot of our providers do not know what those benefits are, and they're changing. So we have had a couple of meetings already with the director of Medicaid about this activity, and we'll be moving that forward. And as Dr. Halliday said, you know, there are a lot of our patients, the data is showing it, that don't understand and know how to manage their risk factors for stroke. And they don't know and understand that heart disease and stroke are related. And so we want to work on some key messages for providers to be used as we train them and be posted on the Start With Your Heart website and shared widely so that we put these messages into simple terms that patients can understand and that we train them on this messaging. And so from there, it led to us realizing that there are other folks out there, there are other organizations and entities and individuals that are doing some work in this regard, like the AAS and other groups. So we decided that what we really need to do is develop a strategic plan to educate providers, and not just primary care providers, but other post-acute providers, just like you all in the COMPASS study as PACs and APPs. You're working with home health, you're working with outpatient, and you're working with lots of other medical providers as well as community-based providers that we're all messaging the same on managing blood pressure and on secondary prevention. So we just wanted to make you aware that this work is going on at the state level. We have been working really hard to come up and narrow down these recommendations. And right before we had the last Stroke Advisory Council meeting on May 23rd, during which we were charged with giving a report, this early COMPASS data, this preliminary data came out, and Dr. Halliday was able to present it just at the right timing point. So we just wanted to make you all aware that this is work that's being done at the state level too. I don't know, Dr. Halliday, if you want to make any closing remarks before we move into some questions, answers, and discussion.
No, I can't wait to hear what folks can contribute to all this, and you know, the real front lines folks. Your ideas, obviously we can't solve everything on a single phone call, but man, you know, just email me. You know, email Sylvia and just, you know, what are your thoughts? What are the local things that might need to be done instead of necessarily the big statewide things? Or, you know, I'm a big believer in the regional, local improvements happening and then connecting across the state. So I really want to hear from others, Sylvia. And also your feedback on actually the presentation itself. I would love it if you just I wish, like residents or medical students or others, just, send some feedback to Sylvia about the presentation and how we could make these things better, because I always want to work to improve how we're communicating with all kinds of stakeholders. So.
Yeah, thank you. You just did an outstanding job, and we can't thank you enough. And Dawn Becker is on, I know, and she knows that that Dr. Halliday stands behind her word. She has been down doing work in Eastern North Carolina and some work specifically with Dawn at Lenoir Memorial and in Lenoir County, engaging primary care providers and practices there. And so we do hope to replicate some of this work across the state, and we know that we can't do it all through Compass, so we do want to, as you all know, we're all about partnering and collaborating, and so we want to do more and more of that. We have an intern with us this summer who is helping us go through all of our Compass data and identify as many primary care providers as we can across the state that have been identified for stroke patients through the Compass study, and get their contact information so that we can look at ways to continue to engage them, but also in this larger perspective from a statewide standpoint through the Stroke Advisory Council. But one question, and please don't be shy, that I would like to ask is, does this data surprise you, or is it kind of what you would expect as you work with these patients and caregivers in regard to what they do seem to know and understand about their risk factors? I'd be really, it's a bit astounding in kind of a negative sort of way, and it does give us a lot of room for improvement, and that's what we are striving to do. But I would be interested in hearing from some of you, just what did you think about the data? Is it about what you would expect? Is it shocking to you? Please chime in.